Thanks very much. And Boo, really congratulations on an outstanding meeting today. And apologies for my absence this morning, considering the schools have been closed in the UK for coronavirus, which was alarming. But back to Endobrain, and the future, I think, is already here. I think without acknowledging my mentors and colleagues, Endobrain would not really be here. And this is Professor Kudo and Yuichi Mori and Sawa Sensei. Really collaboration between the different centers have enabled us to have this practice, certainly in the United Kingdom. Current practice, I want to go through, just take you through a bit of a story about current practice at King's, as what we do in terms of assessment of polyps, and then show you where Endobrain actually fits into that. So initially now, obviously, morphology of colorectal polyps, using magnification endoscopy routinely for pit pattern and vascular pattern, endocytoscopy, which is live histology, and then where Endobrain fits into that. So this is magnification endoscopy with Kudo pit pattern and on chroma endoscopy using indigo carmine, and also crystal violet for looking at 5i and 5n pit pattern. The 5i pit pattern can be in much more detail, and with this crystal violet showing 5i low grade, which is indicative of high grade dysplasia. And then in a bit more detail, this is 5i high grade, indicative of early submucosal cancer. And then you have non-structured pit in that area, which is indicative of deep submucosal invasion. And then these patients would need laparoscopic surgery. Equally so, magnification endoscopy is also used with vascular pattern. And this is a Showa classification for vascular pattern and magnification, looking at the endoscopic diagnosis. And equally now, we're now using the JNET classification, which can differentiate between adenomas, and in particular patients that have type 2B, then those patients would need chroma endoscopy to identify patients that may have early and deep submucosal invasion. The endocytoscope is an integrated type scope, which is similar to any colonoscope. But the advantage really is that you have an objective lens which can have conventional imaging, and you can have magnification endoscopy at that, and then a full zoom, really just sort of push of a lever that can take you up to 520 times zoom. So this endocytoscope, with the MBI mode and also with the stained mode, we would normally stain with methylene blue. And you can see really that on the high magnification image, that you could see the vessels, and this is quite regular vessels here, and you can see the slit-like features that you would see in an adenoma with the nuclei stained with methylene blue. This is now commercially available and was really developed in the upper GI tract by Professor Inoue and then in the lower GI tract by Professor Kudo. But it's been used in practice, certainly in research, for over a decade and then recently been made commercially available. The advantage is that the endocytoscope can give you really a real-time histology. And here you can see staining both with methylene blue and crystal violet. And this is sort of non-neoplastic areas. This is quite normal. This is serrated lumen. You can see slit-like lumen and tubular adenoma, and you can see the lumen itself is slightly irregular, but the nuclei are quite swollen, which you might see in early submucosal invasion, and this is quite destroyed glands that you might see in deep submucosal invasion indeed. And what's interesting is for histopathologists amongst you, you can see quite clear characterization of the endocytoscopic image as what you would see in the H&E staining itself. So you've got hyperplastic polyp, very similar, equally adenoma and submucosal invasive cancer. So, in real time, what do we do? It's methylene blue dye. You magnify up, this is 80 times zoom, then you magnify up, which is 520 times zoom, and this is tubular adenoma that you can see the methylene blue is staining the nuclei quite regularly. This is another polyp here, which is on magnification again, and you can see a slightly serrated lumen, slightly different to the previous exam itself. And equally, this can be done with narrowband imaging, so NBI magnification, quite regular vessels that you can see. You haven't got any distorted vessels or dilatations, and this is fairly regular, indicative of a tubular adenoma. You can see the slits that you would normally see of the lumen in a tubular adenoma itself. So we know, and I think some of the authors have actually already spoken about, what the importance are about automatic sort of colon polyp detection. And we know that obviously if adenoma detection increases, then patients will actually have better outcome in terms of the risk of cancer, decreased rate of cancer that's in these patients. And we also know that adenoma rates are actually often, the adenomas are often missed to quite a high percentage, even in routine endoscopy. But here, actually, with endocytoscopy, we're looking at optical biopsy, and really the optical biopsy has become increasingly important, particularly in Western practice. And that's primarily for two reasons. Because there's an awful amount of money that's been spent around the world, and certainly in the United States alone, they've calculated that there is about a $33 million savings per year for patients that had diminutive adenomas that may have been sent for histology that could potentially have the resect and discard strategy applied if we get the optical biopsy right. And also, in addition to that, is having the diagnose and disregard strategy for patients that may have hyperplastic polyps. We know there are guideline statements on these diminutive adenomas from all the societies around the world. And this is one from the ASGE, and really the diagnose and leave strategy is permitted if the MPV is greater than 90%, and similarly really with the resect and discard policy. So that's what we need to try and aim for as a benchmark in terms of identifying whether these polyp diagnoses, computer-aided diagnosis models are actually appropriate enough to meet those particular PIVI guidance. And we've used it, authors have used it in all these different modalities. I'm going to focus particularly on endocytoscopy. So diminutive polyps, are important because the majority of patients that have screening colonoscopy have polyps that are less than 5 millimeters. And here, for example, in this audience who are expert endoscopists, the question is, which side, which is neoplastic, which is non-neoplastic? And, difficulties to identify, even for the experts, as to which ones are. On the left, we've got neoplastic lesions and adenomas, and these are all hyperplastic lesions itself. And sometimes it is actually confusing. So, where does endocytoscopy and Endobrain fit into this? This is the endocytoscope. This is my colleague Yuichi in Yokohama at Showa University. And the endocytoscope really is just a contact endomicroscope. So you just touch and then you zoom up. It's actually much easier to use than the magnification endoscopy, because with magnification endoscopy you have to maintain that focal length. And the algorithm initially with the initial data itself, which hundreds of thousands of images initially used, and really was the endocytoscopic image that was really filtered and the nuclei that were extracted. And this was actually, in addition to this, they used texture analysis in terms of the differences in the contrast in the endocytoscopic image. And then that was actually then classified as a support vector machine, and then you just have an output which is either non-neoplastic or adenoma. And that was the simple initial data. And the initial series that were used really showed that there was actually high NPV rates that would support the actual PIVI1 and PIVI2 as the ASGE. So quite easy to use. You just essentially just put your scope, as I was saying, and then just push the lever onto the polyp itself. So here we are. Here's a diminutive polyp in the colon, and here's the MBI mode. So all you would do really is contact endomicroscope and then zoom up, and you can see that this is quite clear vessels, and this is very clear vessels here that you can see. And then within 0.2 seconds, it would give you the diagnosis whether this is likely to be non-neoplastic or whether this is neoplastic tissue. Equally here is there's another polyp in the colon, an MBI mode, and then when you magnify up, slightly different vessel pattern that you would see, and this is more likely to be a tubular adenoma, and then therefore the output really is greater than 90% on neoplastic itself. Another interesting case here, we often also use this now in our practice for patients that may have ulcerative colitis, and this is the patient that you see who had a lesion at the appendix orifice, and you can see on magnification here, actually this is probably high-grade dysplasia on magnification. This looks like some areas that may be JNET type 2B and type 2A and others. And then what you would do in real time is just stain the polyp, and you would stain it with crystal violet and then stain it with methylene blue. And once we've stained with methylene blue itself, allow that to stand for a minute so that the nuclei can be stained. And this is a lesion that you can see here. And then we can actually evaluate that lesion in a bit more detail using the endocytoscope and using the Endobrain. So this is now the endocytoscopic image. We're just magging up here. And you can see that there are areas here, the nuclei are you can see the nuclei and the slits in the lumen. And this is actually some areas here. This is more indicative of an adenoma itself rather than actually invasive cancer. So that's where MBI and then staining endomicroscopy can also be useful for endoscopic diagnosis in UC. Just briefly really about some of the data. I think the retrospective data was initially all performed really by Showa University under the authorship of Yuichi Mori and Professor Kudo. And there was data initially with both with NBI mode and also with the stained mode, and they initially showed that there's greater than 90% sensitivities really for adenomatous. This is the data in a bit more detail. And actually, initially, although the sensitivities and specificities were high, they actually, one of the limitations is that they still were not as good, or sometimes equally as good as the experts in endocytoscopy itself. So really, that's what's led to the prospective study evaluation of Endobrain. And this is actually the initial data from Showa University. And this is 791 patients that were prospectively recruited, and there were majority of these were diminutive adenomas. This is the ones that we've been focusing on, and the negative predictive value really for those diminutive adenomas in the retrosigmoid region was very high at 95%, supporting certainly the statements made by the ESGE. I think since the regulatory approval of Endobrain in Japan in 2018 in December, we've now also started an international trial, which is between Oslo, King's, and Showa University. And this is very interesting because the trial here looks at non-expert endoscopists using Endobrain. So patients really, eligible patients are patients that are having screening colonoscopy, and we're selecting patients that have diminutive polyps, and these are with non-expert endoscopists doing the procedure itself. So then they make a diagnosis based on NBI, and then make a diagnosis based on Endobrain, and then we resect all these polyps and send for histology. And the idea is really, can we get non-expert endoscopists in the general community to use Endobrain itself, and then to decide whether patients can either follow the policy of resect and discard in the future, or indeed actually observe and disregard these polyps and leave the hyperplastic polyps in situ. And I think that will be very interesting data, and we hope to report on that hopefully next year. I just want to finish on a couple of things really, is just to talk a little bit about what can be developed and what has been developed, and particularly with Endobrain. This is really looking at automated polyp detection, and we saw this in the previous talk with GI Genius, and that the first pull-through, it was quite difficult to see where the polyp was, and then you've got the automated pull-through again using the AI, and what it does, it highlights a particular area with yellow boxes around to show the adenomatous area itself. Equally, actually, you can have a fully automated diagnosis and detection of polyp, and the optical diagnosis with Endobrain. So here you've got a polyp that's been detected on the automated detection, and then you mag up with the endocytoscope to actually look at this area, and this looks like a tubal adenoma, and then you look at different areas, and you can see the vessels here are quite regular, and this is more like a tubal adenoma. These could potentially fall into the category of the resect and then resect and discard policy. Equally, actually, some interesting developments because also prediction of submucosal invasive cancer, and this requires staining with methylene blue and crystal violet, but also single staining with methylene blue is appropriate. And here we have actually, if you've got an area that's quite distorted glands and distorted nuclei, this is indicative of deep submucosal invasion, and this is invasive cancer, and therefore highlighting the endoscopist potentially to take a biopsy and to send the patient for surgical resection. And finally, I put this for Boo because I know he's very interested in this type of, this is really looking at the activity related to ulcerative colitis with Endobrain, and really what we've got initially is NBI mode with contact on the mucosa, and then you've got ultramagnification at 520 times zoom, and then you've got a diagnostic probability of whether this is active disease indeed, or whether this is actually healing itself. And this needs to be evaluated further, and this is something that's currently in progress. So I think there's a lot going on in terms of artificial intelligence, particularly with AI, and certainly current practice in our institution is really with magnification endoscopy and endocytoscopy, and we're in the process of evaluating Endobrain, certainly in diagnosis of polyps, and then eventually with treatment with ulcerative colitis. But I think really it's very important because endoscopic diagnosis is the key for decision making, and I think particularly so for the large burden of diminutive polyps that we have in general endoscopy. I hope many of you will visit the delights of Camberwell, and endoscopy is in the basement somewhere here, so please join us. And if you don't join us in the basement there, then please join us for our next meeting, which will be held in November. Thank you very much for your time.